Hi everybody, this is Lisa, and we're going to go over the nurse's role in managing assaultive behaviors. This is usually a class I enjoy teaching in person because it's interactive and students get to confront some of these behaviors that make them nervous or uncomfortable or afraid and practice some interventions that could be effective against that. Our objectives in this class are to identify the risk factors and clues that may predict or indicate potential violent behavior and appropriate nursing assessments and interventions which correspond to them. Identify appropriate de-escalation techniques and specific safety measures for the care of the aggressive client, pharmacological therapy for treatment of assaultive behaviors, health education and maintenance needs, and to formulate a plan of care for a client with assaultive behaviors. Our definition of violence is that it connotes extreme, unjustifiable aggression, violating social sanctions, and causing destruction to another as its planned result. Its intent is to inflict harm, to damage, or to violate. Now, unfortunately, this is not uncommon. According to a study by the ER Nurses Association, 67% of all non-fatal workplace violence injuries occur in healthcare settings, but healthcare workers represent only 11.5% of the U.S. workforce. This has been replicated in other studies. And in healthcare settings, violence is most frequent in places you would expect, such as psychiatric units and emergency departments, but also in places that you might not, such as geriatric units where cognitive impairments might cause people to misinterpret and be aggressive over certain types of stimuli, and waiting areas where people are often very anxious and stressed, and there's a lot of chaos in them. Violence and aggression coexist with many types of disorders. These are only a few of them. Most of them involve some level of disinhibition, impulse control disorders, ineffective coping skills. You can see a partial list here. And so now we're going to try and apply the nursing process to a client who has got assaultive or aggressive behaviors. So knowing your patient is an important part of identifying who may be at risk for aggressive or assaultive or violent behaviors. On Barcarolis, there is page 508. There's a full rundown of risk identification factors. But in general, you want to obtain an accurate history of the patient's background, what their usual coping skills are, what the patient's perception of the issue is, if it's possible. Does the patient have a history of violence, substance abuse, psychosis, some type of illness that may predispose them to some sort of aggressive behavior? A history of violence really is the primary risk factor for further episodes of violence. But even in a client who is normally calm, cooperative, docile, if they are stressed enough, they can have an aggressive episode. And so, it's important that we know and anticipate stressors. And some common stressors could be people are in the throes of a really unpleasant substance use withdrawal, for example. They are being threatened by hallucinations. Even pain and coming out of anesthesias and those such things can trigger violent episodes in some people. So we want to know what those common things are as well and plan for strategies to prevent that, to prevent the violence from happening as a result. Now, your general assessment of a client, of course, is going to include their behavior. Are they irritable? Do they have a tense facial expression? Are they pacing? Are they yelling? Are they behaving in a way that would make you think that escalation is possible and a violent episode could happen? What is the environment like? Is it overcrowded? Are there a lot of people on your unit with the same types of aggressive behaviors that are feeding off each other? Is it loud? Do you have staff that is a little timid, not that skilled in engaging these types of behaviors? Have there been inconsistent limits or poor boundaries set in this setting? Oftentimes a client will behave aggressively in the face of a reestablished boundary a nurse or other staff member is trying to set. Box 27 in your book gives, again, some other predictors of violence you might want to look through. And again, what's your own self-assessment around this? Are you engaging in behaviors or giving signals that is making the situation worse, not better? Do you have particular triggers that might make you react to a patient or a behavior in a certain way? What does your body language say? Is it closed? Do you have a tense face? And what is your word choice? Are you behaving in a defensive manner, for example? So always be sure to do kind of a self-scan to make sure that your behaviors are not contributing to the problem as well. Your nursing diagnoses, of course, arises from your assessment. And while we're primarily talking about other directed violence here, it's entirely possible that a client could turn on themselves and begin hitting and engaging in some self-injurious behavior. So you want to be on guard for that as well. For your goals, for your outcomes identification, of course, the primary thing is that you want the patient and others to be free from harm. That's going to be your priority diagnosis or your priority outcome, no matter what else. For self-management, self-care types of strategies, you want your client to be able to identify some triggers for outbursts. What was happening when the client became violent? What are some safe alternatives to those aggressive behaviors? So this time you lashed out at somebody. What is an alternative behavior that we can practice here that will be safer? And you want to identify healthy coping mechanisms for stress management. People who have violent outbursts and aggressive behaviors very often have some very immature, unhealthy coping skills. So you really want to help people sit and identify what is a healthier way of dealing with stress management so they don't get to that spot where they are engaging in aggressive behavior. Now, your book has trauma-informed care under assessment. I personally think it belongs under implementation, so I put it here. But trauma-informed care is a philosophy that basically says that all of us probably have something in our background that might predispose us under certain or specific circumstances to have aggressive or violent outbursts. And so we are going to care for people in a way that will prevent that. Disruptive patients often do have histories that include violence and victimization. These histories can impede patients' abilities to self-soothe, to engage in self-regulation, and that will result in some negative coping responses such as attacking people, lashing out violently. And then in order to maintain safety, the client is then, and the staff puts the client in a hold, put them in restraint, put them in seclusion, which leads to re-traumatization for the client. So it becomes a very vicious cycle. And trauma-informed care really does try to work to stop that cycle. Again, this is not in your book, but I do think that you're going to hear it when you're out in your facilities. So I think it's important to know what it is. And it shouldn't look a whole lot different than a lot of stuff that we've been talking about for the past 3 semesters now. Trauma-informed care creates a physically and emotionally safe environment, establishes trust, understands what the boundaries are, supports a client's autonomy and the ability to choose safer behaviors, and believes in creating collaborative relationships and abilities for clients to succeed using a strengths model. So the idea that every client has strengths that you can build on to aid in recovery is really key to a trauma-informed care model. Now, for some general implementation, you ideally want to begin this before somebody escalates. You want to be proactive and not reactive. You want to be able to prevent the outburst rather than respond to the outburst. And again, this requires establishing trust. It helps to have some frequent interactions, non-threatening ones with the client. And depending on where it is that you work, areas where this is certainly expected and bound to happen, you'll have some de-escalation training. The staff should all know how to manage a client who is in a state of escalation. There's a number of different ones out there. There is Patients First, Safety Care, Moab, a bunch of different ones. It's just going to depend on what they're all about the same. It's going to depend on what your facility chooses and where you work. There are psychosocial interventions. One of them is that you maintain calm and you don't take it personally. It is very difficult to do that sometimes when people are in your face and they are yelling. Their blood pressure is up, their heart rate is up, and yours is going to be as well because you're going to be in a fight or flight reaction. But just like heightened emotions are catching, so are calm. It is very difficult for somebody to maintain a screaming, heightened, angry, emotional state in the face of somebody who is very calm. So that's probably the most important thing that we can start with. Maintain your calm and don't take it personally. You want to make sure you've got safe space. You want to keep a good, at least a foot further than the person can reach, so that you have time to react if somebody wants to attack you. You want to make sure you have a clear path to the exit. You want to make sure that there is nothing between you and the door in case the situation escalates. I was working at Spring Harbor a few years ago, and one of the psychiatrists, who was just a little woman, took a patient down to the end of the hall. And she, you tend to get, your guard drops a little bit when you've been doing this for a while, nothing is happening. The people that around you seem fine. She took a client into the room. She sat at one end of the table. The client sat at the other with the door to the back of the client. And the client did get up and become physically aggressive with the psychiatrist. And the psychiatrist was very lucky that a couple of techs were right around and were able to pull the patient off her. But always be aware of your surroundings and aware that this is something that can happen. You want to acknowledge the patient's feelings and needs. But you also want to set limits on the behavior. The patient doesn't have carte blanche to behave in any way they feel. So to say something like, I understand that you're upset, that you had a difficult conversation with your spouse, but it is not okay to yell and hit the wall. And let them know that they're going to need to stop that. Because that behavior is not, while the feeling is acceptable, the behavior is not. If possible, you want to give the client some options. Clients very often will lash out when they don't feel like they have any options, when they feel very cornered. So by saying to them, I understand that you're angry. Would you like to take a walk, or would you like to go sit down in the community area? That gives them at least a little bit of semblance of control around what activity that they do. You want to make sure that the environment is calm, particularly if you're in a unit or something like that where somebody is in the middle of the unit, near the nurse's station, whatever, having an outburst. It's very, very helpful to have somebody go and direct, and it's going to attract attention. And it's very helpful to have somebody go and direct other people away from it. Say, geez, this person is having a really hard time. It would be really nice if we could give them some privacy, and have people move other clients away. But you also want to make sure that you have some backup close by in case the situation does escalate, in case these de-escalation techniques that you are trying to put forth don't really work. And again, you want to model controlled behavior. No matter what the client is doing, you remain calm and in control. Your personal safety is always paramount, because if you are not safe, you cannot help anybody else be safe. And it's, nobody wants to end up being injured on their workplace. And there are things you can do to make that more likely. Just for your own person, no dangling jewelry, no scarves, no necklaces. Always think of what can be weaponized. So you don't want to do anything that somebody can grab, whether it be a little, a little old woman who's got dementia who grabs onto an earring and rips it, or somebody who grabs the scarf and tries to strangle you with it. Everything that you bring to you, just be in mind of how it can be used. If you've got long hair, keep it up, tie it up on a bun, clip it, something. Don't use a ponytail because a ponytail can be grabbed. So always bear in mind what you've got on you that can be used as a weapon against you. Make sure that you've got staff close by if somebody is aggressive and escalating. It's not often helpful to threaten a client with a bunch of people around, although you will see it happen. But you do want to make sure that while you are attempting a de-escalation or having a conversation with the client, that there are enough people close by to help you out if the situation escalates. One person should talk to the client while this is going on. Ideally, it's a person that the client has had some sort of positive relationship with. You want to know the layout of your area. You want to make sure that it is clear. If a client is aggressive and escalating, you want to make sure that their tables and chairs are out of the way, that there's a clear path to the exit, because you don't know when something is going to happen and somebody might throw something, or you need to have room to put the client in the hold or something like that. And you want to stand to the side. You don't want to stand directly in front of a client. That can be pretty confrontational. Or you want to encourage seating. And if you want to maintain eye level with the client, you don't want to be towering over them. And it's harder to maintain a level of escalation while you're sitting than while you're standing. So those are some of the things you can do for your own personal types of safety. Pharmacology, I'm just going to touch on. We've gone over these meds before. We're just using them in a different setting. There is if somebody come in and they are acutely aggressive, out of control, you may need to use some meds to get the client back in a safe spot, PO, IM, depending on what the situation is. Very often you'll see anti-anxiety meds, benzos, usually something like Ativan, works quick. And either first or second generation antipsychotics, which will help calm the behavior. Very often you'll see a combination of 10 of Haldol, 2 of Ativan, and then something given Benadryl, given to calm the EPS that may occur if you're giving a first generation, particularly antipsychotic, to somebody who is not used to them. Haldol is very popular in use, but there are a lot of other drugs that people use. There's also chronic management that happens for people who have chronic issues with aggressive behaviors. And a lot of times I'm thinking of clients who have got autism spectrum disorder, for example, or head traumas. And we'll use a bunch of different meds to try and manage this depending on how the client reacts, really. SSRIs can be used, lithium carbonate, anticonvulsants, benzos, beta blockers, second generations. Sometimes in kids you'll see stimulants used like methylphenidate. Sometimes, in spite of all of our best efforts, de-escalation doesn't work. The client escalates to a violent behavior and actually attempts to strike somebody or hurt somebody. And at that point, you go to a seclusion or restraint, depending on what's going on. Seclusion, involuntary confinement, alone in a room that the patient is physically prevented from leaving. And then there's restraints, which are any manual method, physical or mechanical device, material, or equipment that restricts the freedom of movement. In adults, that's very often 4-point leather restraints. In kids, a papoose wrap or something like that can be used to calm behavior, keep people safe. Now, we did go over a lot of this in second semester when we did legal and ethical, and we've talked about it off and on all along. But just a reminder of what is appropriate use of mechanical restraints. The indication for use is always going to be to protect the patient or somebody else from harm. Shouldn't be used in a punitive way. Patient shouldn't be threatened with it. The only indication for use is that the patient is that harm is imminent. There are some contraindications for use. People have died in these. So they really have to be used judiciously and for one purpose only. Legal requirements are usually that an appropriate healthcare provider has ordered them. Now, a nurse can implement them if the situation is dire enough. If there's legal if there is imminent risk and the patient needs them, but you need to get an order as soon afterwards as possible. That there is notification of either an advocate or a relative, and that we discontinue the restraints as soon as we possibly can. We need to know what was the behavior heading up to it. We need to document what least restrictive methods were used before we went to these. Now, sometimes, particularly if somebody's coming into the ED or something like that, there is no other restrictive method that can be used. That is the least restrictive method, but generally, did you offer a PRN, for example, or something before you went to the mechanical restraints? What was the patient's mental status at the time of the restraint? Was there a physical exam done afterwards for review for some medical problems that could have been causing the behavioral changes? Those are some of the clinical assessments that they'll be looking for. Staff needs to be in constant attendance if somebody is in a mechanical restraint. There needs to be a one-to-one person looking at them all the time. That is something that can be delegated to somebody who has had some training in this type of observation. But basically, yes, the patient can't be left alone. There has to be vital signs monitored regularly, range of motion, the opportunity for toileting. Those types of things have to be offered to the client. The release procedure is basically that the client is able to follow direction and able to maintain control. There is a debrief procedure offered to the client. Sometimes they take it, sometimes they don't. And for restraint tips, basically know that anything that you are doing that restrains a client from movement can be considered a restraint. So even if you have a client on the floor and you are holding them on the floor, that's a restraint. And you cannot, again, use a PRN for a restraint order. Debriefing is needed after a traumatic event, such as an episode of aggression or violence that results in restraint or seclusion, with individuals that are considered to be under stress from that trauma exposure. And I think it's fair to say that restraint and seclusion procedures are traumatizing, certainly for the patient, but they're also traumatizing for the staff that go with them. It's a very unpleasant thing to go through. So the client is going to be offered it, the nurse, assistive personnel, medical staff, whoever was involved directly in the action. And a debrief is basically a critical review of what happened with emphasis on support and prevention. So immediately afterwards, a facilitator, it might be the charge nurse, it might be the nursing supervisor, it might be the provider, whoever it happens to be. It couldn't be anybody. Gets the group together to review what happened and how people are feeling about it. Now, what was the behavior that led up to it? Were there indications earlier that we missed? How did the restraint and go itself? Were there actions that we might have taken that we didn't? And with the idea that we can do it better the next time, that we can avoid it the next time. So to review from top to bottom what happened, what was the risk, how was it handled, did we miss anything, what could we do better next time, is basically what a debriefing is designed to do. And finally, I do want to talk about psychiatric emergencies a little bit. It's not in your book, but I do want to let you know that it exists as a law in Maine, and that a patient, whether voluntary or involuntary, may be treated without informed consent under very limited circumstances for a very limited period of time in an emergency. And an emergency is defined as basically a patient's behavior due to a mental illness where there exists a risk of imminent bodily injury to the patient or to others. So a patient must have a mental illness. A patient must be exhibiting behaviors that puts themselves or others at risk. And that the treatment is required right now. It can't be deferred long enough to find somebody to consent to it. And that a reasonable person concerned for the physical safety of the patient or others would consent to the treatment if given the opportunity. And so the person who is ordering the emergency treatment, that is your physician or physician extender generally, has to document the behaviors that created the emergency and document them clearly enough to show the imminent risk. The person who orders the treatment also has to document the period that you're going to administer the medication, and it's usually an antipsychotic of some sort and some benzos, and what they expect the benefits of that treatment to be. The client behavior will cease. The client will no longer be at imminent risk to himself and others around. What behaviors the staff should monitor and how the staff should monitor the patient's behaviors and respond to treatment. So very often you'll see an order for an antipsychotic, and I'm going to use haloperidol because it's easy. Haloperidol, 5 milligrams or 2 milligrams at scheduled times, and then if behavior reoccurs, a PRN ordered as well. And that has to be documented pretty clearly in order to sustain the psychiatric emergency. The treatment can only continue for as long as the emergency continues. So once the client stops being an imminent danger to self and others, then the treatment must be discontinued. It's not enough to initiate an emergency just because the client declines treatment. There has to be a whole lot of other things going on in order for that to be something legal to do. Okay, that's what I have for you for class time. There are some activities to complete. There's a case study in there with the patient, Mr. Bravo, and Eric, the clinician. There is a Kahoot challenge for you to finish. And in your third touch, there is a nursing skill form that you can use to complete de-escalation and care of the client in mechanical restraints. Thanks, everybody, and have a good rest of the day.